Welcome everyone, and thank you for joining us for another episode of Aging Gracefully, a talk show for Evergreens. Our discussion for today is on another topic, coping with mental health issues of aging. I would like to introduce you to our exceptional panel of speakers. Most of y'all will know Father Juvi. Father Juvi has been with us in all our previous episodes, and Father Juvi is a scripture scholar. He's been in the General Council in Rome for many years. Welcome back, Father Juvi. We have Dr. Angeliqueka. She's a psychiatrist from practicing in London, and she's originally from Bangalore, where she qualified as a doctor. She later moved to London, where she trained as a psychiatrist. Welcome, Dr. Angeliqueka.
Thank you. Thanks, Gila.
And welcome, dear audience. I hope you will find this discussion helpful. The impact of mental health issues on the elderly can be significant, affecting their relationships, their ability to function independently, and their quality of life.
And I'm really happy that you are here, Dr. Angeliqueka, but she prefers to be known as Angelica because she's been following us regularly through the RMC programs from London. And so it's so nice to have you back here.
Thank you.
In the city where you grew up and amongst the people whom you are now familiar, at least through the RMC.
Absolutely.
Thank you for coming.
You're welcome.
So our first question, Doctor, I'll pose to you. What mental health difficulties do the elderly have?
Okay, Gila. Elderly people can suffer a range of mental illnesses, mental difficulties. It could be depression, it could be psychosis, and dementia is the most common mental illness that elderly people suffer. With regard to depression, once you get to a certain age of life, you feel that you've lost your purpose. You know, you retire from work, the children are grown, grandchildren may not be in the same city. And there's a sense of being isolated, there's a sense of being purposeless. And that can lead to a clinical depression. Psychosis is a more serious condition where if you're very depressed, you can become psychotic. If you have dementia, you can become psychotic. You can have a pure psychotic illness, which comes up later in life. But dementia is really what we focus on with the elderly.
As we grow older, we begin to see that our energies diminish, our physical capabilities diminish, but also our mental faculties are not what they used to be. Sometimes as we grow older, we think we're having a kind of a memory loss. Is it something more than just a memory loss related to aging? Or is what would really come under the title of dementia? Because sometimes we use these words interchangeably. Mm-hmm. So it would be helpful for a professional to express in layperson's terms how these things really come upon us and how we address them, how we deal with them.
Okay, good question, Father Juvi. So about the age of 65 onwards, we develop what we call a mild cognitive difficulty. So you don't know where you've left your keys, you forget someone's name, you go into a room and you can't remember what you went there for. All of that is very normal, very normal. It's part of the aging process. It's not progressive. And I think that is the main difference between just a mild cognitive difficulty, a mild memory problem, and dementia. So dementia, by its definition, is a memory loss that becomes more and more serious. And as it progresses, it actually impacts on your functioning, your everyday functioning. So things that you do normally start to become a bit complicated, a bit confusing to you. You can't sequence events. You can't sequence things like getting dressed, for example. In the later stages, people find it difficult to know how to put a button on, or which goes first, your shirt or your vest, or so things like that. So that's the difference between dementia and mild memory problems. We all have mild memory problems. Younger people as well, who might be very depressed or unable to focus, or there are so many reasons that someone can have a memory loss or a memory problem. But when it's progressive and it's far more serious with its impact on your daily living, is when we then define that as dementia.
Thank you for making that distinction between this memory loss or cognitive impairment and the real struggle with dementia. Now, sometimes when people use the word dementia, in most cases they think of loss of memory. But sometimes there are other aspects also, like, loss of judgment, lack of inhibitions, persons who were really someone who had it all there and then suddenly something comes to pieces or unravels. Maybe, again, a little light on that might enable us to
Sure.
go deeper into this whole issue of dementia that you've laid out generally for all of us.
Sure. So dementia is an umbrella term. Within dementia, you have Alzheimer's, which is about 65% of the the kinds of dementia. You also have frontal lobe dementia. You have a vascular dementia, and then you've got dementias that are a result of illnesses, like Parkinson's, for example. So 60 to 65% of people who have dementia will have Alzheimer's dementia. And Alzheimer's brings with it behavioral changes, psychological changes, functional changes, which you find not only progressive, but also very distressing. So the difference one of the differences between Alzheimer's and the vascular dementia will be that with the vascular dementia, there's a big mood component. So people are more tearful, they're more angry, their moods are up and down. So what do I mean by Alzheimer's? So Alzheimer's dementia is caused by plaques of amyloid, and those are all technical terms. But there are plaques in your brain that block the neurotransmission. So when we have a thought, so if I say, right, I want to stand up, my brain and the nerves will then send a message to my legs to say, right, let's stand. When you have these plaques blocking those channels, you know you want to stand, but the message is not getting through to your legs. Or you want to pick something up. So you're sitting there thinking, I want to do it, but it's not happening. And the block is there. And that is what really leads to the frustration. So you get behavioral changes. So, people are getting more frustrated, they're getting more irritable, getting more confused. So it's almost like your brain is short-circuiting itself, With a vascular dementia, well, one thing to mention about Alzheimer's is the progression is very downhill. It's very gradual and it's very downhill. It doesn't stabilize at any time. With a vascular dementia, it comes usually because of high blood pressure, diabetes, high cholesterol, smoking, stress, where the blood vessels of the brain is blocked with actual clots, like a stroke. And then in that you will get a stepwise decline. So someone will have a little blood clot in a small vessel, and they'll go downhill, and then they'll be stable for a while, and then they'll go downhill again. So that's the main difference from a clinical point of view. That's how you would know which dementia it is. I mean, obviously with other MRIs and CTIs and things. The other dementia is the frontotemporal dementia, where the frontal lobe of the brain is affected, again, due to various changes in blood vessels, changes in the proteins in the brain. And with that, we get a huge behavioral problem. So the person behaves out of character, is very disinhibited, lose his or her executive functioning. So the frontal lobe of the brain is where we have our executive functioning. So how to speak, how to carry yourself, how to manage a budget, how to, the finer points of our intellect. And that seems to diminish quite quickly. And with a frontal lobe dementia, it can happen in the ages of 45, 50, 55. It's a younger dementia. And then the last kind of dementia is due to illness. So when you have Parkinson's, you have a Parkinsonian dementia. If you have Huntington's, you also have a dementia with that. Korsakov's with alcoholics. So you have a dementia secondary to an illness. So that's broadly those are the kinds of dementia.
My mother-in-law has got this
Tremor.
Is that does it come under any of the dementia, or what is it? Just a tremor. Just her hands.
Okay.
She can't hold anything.
Yeah.
And
So there are various neurological reasons why someone might have a tremor, and that needs to be investigated because it could indicate as time goes on that she'll have Parkinson's.
Oh. And so
Or
what
it
is
could just
Parkin-
be a tremor.
Oh, it could be. She's
Yeah.
91.
Bless her.
Yeah. So, but what is Parkinson's? Is that also, they say
Parkinson's is
normally?
a whole different neurological
Oh, is it?
illness,
Okay.
Which for another day.
Yes,
But
yes.
the reason I mentioned it is because you can become quite confused with Parkinson's because it affects parts of your brain.
Yeah, okay. All right. Thank you so much. Yeah.
I just want to thank you for just laying this all out over there on the table. This is a talk show. We're not here dispensing professional psychiatric advice, although we have a professional psychiatrist in our midst. It's a kind of a disclaimer, because what it means is these are things that you might be facing in your home, in your families, people you know.
Yes.
And hopefully through this conversation, you might help understand them better,
Yeah.
and then take them to get it properly attended to with appropriate tests, so that you know what we are laying out as indicators, you will take it to its conclusion with a formal examination, doing the test. Now, related to that, because you threw in the other aspect about the neurologist, do they take them to a psychiatrist or a neurologist or both? I mean, how is that going to work?
Okay, so neurology and psychiatry work quite closely together. By and large, if you go to a neurologist with a set of complaints like I've mentioned, they will refer you to a psychiatrist. Sometimes neurologists feel able to treat dementias, themselves. But if you go to a psychiatrist with a tremor, for example, and dementia, then most certainly you will need to see a neurologist as well. So, we try and keep our specialties quite discreet, but we work closely together, so, yeah.
I have a question about what you just said. I'm a little confused about the different kinds of dementia. Alzheimer's is mainly memory loss, is it? Starts with that.
All of them have memory loss.
Oh, okay.
The frontotemporal, the memory loss comes later. But Alzheimer's, the primary symptom is memory loss, by which we diagnose it.
Yeah, because I do know several people.
Yeah.
Many of them it's age related. But I know one person who seems to have got Alzheimer's rather young.
Yes.
Her memory loss, I was told by the neurologist, when she was 67, I was told by the neurologist who did the test that it had started 6 years earlier, which means 61.
Yes.
And for a long time she was very stable. So it was not a gradual decline and all. In fact, I was hoping it was depression rather than dementia. But then, of course, now one can see the deterioration quite well. But she's not yet that confused about putting on her clothes and things like that. It's mainly memory. And there was something else I think you mentioned about
Executive
maybe
functioning.
imagining.
Or hallucinating.
Yes,
Okay.
yes. And she can't handle running her home or anything like that. In her mind, she's perfectly able to do all that.
Yeah.
So it becomes a little difficult
Yes.
to manage.
Yes.
And I think that's with most people who have dementia. And also, they cover up beautifully. I mean, I
They
know
do.
a lot, 2 aunts of mine,
Yes.
and they cover up beautifully. They haven't a clue who I am, but they'll talk as if, they know me so well.
Yes.
So it's difficult then to kind of find out exactly where somebody is at.
Okay, so I guess your question is where in the progressive illness is she? So again, the way someone presents, every illness has a broad definition, broad symptoms, but it's very idiosyncratic. It is very dependent on the person. So you described her having a period of stability, and that could be attributed to the fact that it started so young. And now the decline, you will see progressively. Yes, absolutely, she can dress herself. She doesn't have incontinence problems. She doesn't have what we call the behavioral and psychological difficulties in dementia. But that is something that will happen later. It progresses to that. So at the moment, budgeting might be an issue. Shopping might be an issue. She might go to the shops and not be able to actually get everything she needs, or she won't know how to sequence it. That's where the difficulties come. But also with dementia, a kind of note is first in, last out. So what I mean is things that you learn as a child and as growing up will be the last things you forget. Things that you learn later in life will be the first things you forget. So you might say she's so confused, but still she can say her rosary. So that's something that she's imbibed as a child or as a young person, and that comes automatically. So what we say, the things that you learn earlier are the things you forget last. But later on in life, things that you learn, like driving, for example, that usually happens in adulthood. That becomes an issue for them. So perfectly good drivers will have frequent accidents. They are unable then to focus. Red light, what does red light mean? Do I go? Do I stop? And that's how the confusion becomes a danger to them and others. So unfortunately, those are symptoms as the illness progresses that one has to watch out for. And I think we'll talk about that a bit later in how carers cope with people with dementia.
Thank you.
You're welcome.
Thank you for that, both this interaction as well, what you said earlier, because it leads me to a point that I've been trying to grapple with. What one must do so that we can prevent it or delay it or slow it down, or as some people live in hope of a cure. Because, it sort of unravels, unfolds. So is there, knowing that this is going to be a progression, what can best be done? I think would be something. Because it manifests, it sounds like a question, but it manifests itself in a series of behaviors that some of which both of you spelt out so clearly, like people who are not the persons they once used to be. We spoke about lack of inhibition. Someday you're in a hospital and the nurse comes to care for you and you think that nurse shows a particular romantic interest in you, which would be so much out of character with you. So, maybe if you can just take us down this continuum, what we can to prevent, or what we could do to slow down. Or some people live in hope of a cure when in a situation like this. So maybe a little more light would bring us out of the darkness.
I'll address your last point first, Father Juvie. So in terms of a cure, despite the best research in the world and the ongoing progress in the research, there isn't a definite cure for dementia. There are various medications that help slow it down, especially if it's Alzheimer's. And there are medications that we give patients to manage their behavioral difficulties, the irritability, the wandering, things like that. But an absolute cure, no, not yet. Let's take an individual who has high blood pressure, cholesterol, diabetes, smokes, has a stressful life. All of that needs to be controlled. So it's lifestyle choices, it's diet, it's exercise, it's cutting out on anything that's going to deteriorate your physical health, because that will have an impact on your mental health. With Alzheimer's, there's very little you can do in terms of lifestyle choices. I mean, living a healthy life is always a good thing. But what we very strongly advocate is when you notice that someone's becoming forgetful, like your friend, for example, mental stimulation is hugely important, keeping them mentally stimulated. The way our society is moving today, maybe not so much in India, but abroad, people are very isolated. The elderly are very isolated. The physical contact with other people is minimal. Yes, they sit and watch television, but it's not an interaction. And that, therefore, the brain activity isn't as much as it would be if you had people in the house and you're living with them. So keep them mentally stimulated, puzzles, crosswords, anything that will keep them thinking. Other than that is human contact activities, getting them out. Those are things that will delay it, but not stop it. And obviously with other illnesses like Parkinson's and things, you have medication that should help, but it's more how you manage an illness as opposed to cure it or treat it, because it's not entirely treatable. The symptoms are treatable. So the irritability, you can give something, that kind of thing, but sleep. Also, another important thing I forgot to mention is we have the sundowning effect. So most people with dementia, whatever kind of dementia it is, as you get to evening, you will notice the irritability, the aggression, the restlessness, all of that starts to pick up. So it's called the sundowning effect. Difficult to know why. Could be just a change in light that, they become insecure. Many times you'll find people open the door and wander away in the evenings because staying home is very difficult. So medication will help with that irritability and that confusion, but in terms of the actual illness, the treatment is just symptomatic, really.
Thank you for laying it all that, spelling it out first. I'm going back to my Sudoku and my crossword.
Me too.
I had the privilege of looking after my mother-in-law the last 10 years of her life, and she expired 2 years back at the age of 98. I remember she was taking 2 mg aspirin throughout her life.
Yes.
So, and she was a perfect health of the memory and all sorts of things, doing a routine and with the diet.
Yes.
So, taking aspirin, will it help for the, for the slowdown of the dementia?
Okay.
Or any other sort? So, which just a clarification.
Sure. So, taking aspirin is what we suggest to keep your blood thin enough to pass through the blood vessels. So, if someone has hypertension, diabetes, cholesterol, the things that I mentioned earlier, the doctors advise you to take aspirin. Is it directly linked to treating dementia? Not at all. Yeah, but it helps keep you healthy so that there is no effect on your the small vessels, small blood vessels in your brain. Because when your blood is thicker, you have minor strokes, major strokes, heart attacks. So when you keep your blood thinner, it can travel through your body easier, and therefore it's not getting stuck in the small vessels and causing minor strokes, which leads to vascular dementia.
Doctor, I have a brother who got early onset dementia. And in his, he was around 55, 56. So he started arguing. He was confused about a lot of things. And we thought he was having some kind of mental breakdown. We took him to a psychiatrist. They were treating, that it went from him becoming a zombie to then reducing till it took some time to actually get a diagnosis of dementia that was troubling him. But one thing I wanted to ask about is that when he was in hospital, he was actually in hospital because we couldn't look after him. And the one general practitioner was called in, and she discovered he was keeping his sugar level at 60 and 70. He was living in a home at that time as a bachelor, and he took early retirement. And so he was on medication, plus he was on diet. And she saw that every week he had kept his chart and was 60 and 70. Yes. And she said that is what have caused his early onset. Is that possible?
Okay. So, Evelyn, reality is if you go to 10 doctors, you'll get 10 different diagnoses and 10 different opinions. What I would suggest is that when someone has a very low blood sugar, they can become irritable, they can become forgetful, they can be confused, absolutely. However, there are other symptoms that go along with that would point us in that direction. Early onset dementia, sadly, is a very real phenomenon.
And it progressed once it progressed very fast. He couldn't even remember the rosary. Yes. The prayers of the rosary would call me up before the rosary was staying in a home, and he would ask me to, we would kind of practice the Our Father. It was very sad.
Yeah, it is very sad. It's very difficult to watch for loved ones. But can low blood sugar cause dementia? In my opinion, no. It isn't the cause. It can exacerbate it, but it isn't the cause. The etiology won't be won't be a persistent low blood sugar. Because if it was that low, he would have had other symptoms, which would have been picked up. But it didn't help. Let's put it that way. Yeah. It didn't help.
As you said, keeping your physical health good.
Absolutely. Yeah.
Thank you.
So, And the irritability and the mood swings, are very common in dementia, more common in a vascular dementia than Alzheimer's. But Alzheimer's, you do get it as it progresses because they're so frustrated. And you go and tell them, you can't remember. Don't you remember this? I remember. Of course I remember, It's like, how dare you? Because they don't see it. The insight is gone. So, when someone has dementia, the very, very challenging time for them personally is initially. When they're in that gray area where they know something is wrong, they know they can't remember, they know they're confused, but not all the time. And that's very hard for them. Once they cross a certain stage where they are completely confused and have very little memory, then it doesn't affect them because they don't know it, but it's the early stages that's very hard. And that's why the irritability.
Some people don't seem to have that awareness. They just think, okay, I can't remember things. I'm scatty. I myself feel that way. So, is it good to tell them that they're going in for dementia or not? I know doctors normally think a patient should be informed about everything. But I do know one case where a very close doctor friend of the patient decided that she should not be told because she couldn't handle it. And it might cause worse problems. First denial and then deep depression. So I'd like you to shed some light on that.
Sure. Goes back to my response to Evelyn earlier. You ask 10 doctors their opinions, you'll get 10 different opinions. The way we practice, or the way I practice, is transparency is hugely important. Yes, they won't be able to handle it. It's a life-changing diagnosis you're giving them. And it is very hard. It is incredibly hard. But alongside with that goes all the counseling and the support and the psychoeducation to kind of soften the blow, if you like. But I think it's crucial that a patient knows where they're heading, because there may be so many issues they need to sort out and solve before it becomes too late. And this is something we'll talk about later, the legal aspects of dementia. I think they need to know enough to be able to plan their lives. They need to know enough to feel in control for as long as they can be, and to put things in place, as difficult as it is. It's a bitter pill to swallow, but you'd rather know and plan than just slip into this kind of forgetfulness and confusion and not have taken care of things that you want to and still can. So that would be, and depression goes hand in hand with dementia. A lot of cases, 80% of dementia cases, whichever category it is, will have depressive symptoms because everything is slowing down. So you will have an overlap of depression, of psychosis, but my personal belief is that you need to be transparent with them so that they can sort out things and plan either which way. I mean, it's a two-sided coin. I think Father Sandeep and myself had a brief conversation many months ago about a couple. The husband was getting progressively more forgetful and confused. This was a gentleman who's a very high achiever in his life, and for the wife, his wife for 60 years, it was very hard to watch. And so they had a suicide pact. And you see, so knowing can also have its downside, but that's 1 in a million. It's always better to be transparent so that someone knows where they are. Yeah.
Thank you.
Father Juvi, how do the carers cope with the changes that occur in their loved ones, their temperaments, their personality, their behavior? So how would you talk about it in the pastoral aspect?
Okay. This comes not from any specific textbook, but largely through the experience of life, that not only interacting with people going through this phase of their life, as well as their caregivers. And I would really see it in 2 dimensions. One is how the caregiver is relating with this person. It could be a family member, it could be somebody who's employed, whoever's taking care of this particular person, and their interaction. And the second part, perhaps we might look a little later, is what does this carer need to do for oneself in such a situation? because there would be actually, I would see it as two different aspects to this one dimension of caregiving. Especially with family members, you're dealing with something that is so new to them. So while their loved one is going through this, some of it not totally aware of it, but the family members who are there to care. We've had a whole session on caregivers in the previous episodes we've done. But I think we need to look at it now, particularly from the point of view of mental health. Okay. When it comes to family members, and I've had quite a few who've shared things with me, some of whom were a bit reticent about coming on this program, because first of all, to see their loved ones going down this road of decline, it does things to them, and they have to learn new ways of interacting, new ways of communicating, because the older ones just don't seem to work. So it's a process where both are really stumbling or fumbling, and therefore it certainly helps to read a lot more, because now there is so much of material that is available for that. You get support groups even online of how you can share experiences, because it's so important externally to gain resources to deal in an even better way with this person going through this condition. Internally also, you're beginning to see this person. At one stage, maybe it was your parent who did things for you, but now the shoe is on the other foot. To do some things, you saw this parent as this all-powerful, wonderful person able to handle every situation, and now they're just crumbling before your eyes. It really takes, so how are you going to, sometimes words are not enough, or words cannot be grasped, or you're still so confused with that. And sometimes you're just communicating with a touch, with a reassuring hug, you're using non-verbals, because that is saying something that words do not seem to be getting through to them. And I think that's another dimension. Another thing is, I like the phrase first in, last out, because that phrase of, say, for example, praying the rosary. While so many other things might be fading out of the memory, they might even forget what the mysteries are of the rosary. But once you just start off the Our Father, they just sail on. And so at one time they might have looked as a routine prayer, now is their salvation, because that's the way of connecting with. So I think the caregiver is dealing with aspects within themselves, in their relationship, and how they bring this dimension of spirituality, which has meant so much to them. For some, of course, they never had this aspect about spirituality, but that does not mean that God has abandoned them. Okay? But if spirituality is something that has been part of them, this would be such a wonderful resource at this moment, together with all the medical resources, with all the psychological resources, that faith also becomes something that will strengthen this person. What perhaps the caregiver can do for this person is to give them the reassurance that they're not abandoned. I like what you said, just the physical presence in the room will be a sign of assurance that we are not abandoned. Not lonely, not left out. Because these are people. Let's not forget. They are not persons with a diagnostic condition labeled onto them. They have gone through these aspects of, and so what the carer can do is precisely to do that. Another dimension is sometimes the family cannot be around, okay? And sometimes they have to depend on caregivers who are not part of the family circle, perhaps someone who's paid. And therefore, in choosing somebody, you have to screen and make sure, because will that person really be helpful? Because it has to be a good fit. The person who's coming in as a paid or a professional caregiver has to be a good fit, because sometimes they can, for whatever reason this person is going through, there is a certain antipathy that we cannot understand, and perhaps you might throw light on that. So there are these factors that also a caregiver needs to be taken. To reassure, to be present, and to sustain this relationship, even though this person might seem far gone, although present in the very room itself.
Thank you, Father. Thank you. I can pass this question to Angeliqueka.
Thank you, Gila. So when we think about carers and caregiving, Father Juvi's covered quite a bit. But we divide it into the psychological effects on the carers, the physical effects on the carers, and the social effects on the carers. So if we look at the psychological effects, as Father Juvie said, if it's a parent who's got dementia, then this wonderful tower of strength is, now dependent on you, which is quite difficult. If it's a partner, a wife, or a husband, then all the dreams and aspirations you had for your, sunset years are all fading away. You wanted to travel, you have no responsibilities, everything you want to do now is just taken away from you. So psychologically, it's gearing yourself up to a bereavement that is ongoing and slow. When someone passes away, it's terribly painful and that lasts with you, but you're not living it every day.
Yes.
And I think with dementia, sadly, you're losing a bit of that person every day, almost so that they become unrecognizable, their personality, their behaviors. So psychologically, that has a huge impact on the family and the caregiver. If it's a professional caregiver, there is that little bit of distance that, it's not with your heart, it's a professional, but the caring is still there, the impact is still there. The physical aspects are what carers struggle with the most. So as they become more and more confused, the wandering starts. So they open the door and they walk out and they get lost and somebody brings them back home if you're lucky. So it's this constant vigil. I have to either lock the door, I have to know where he is, I can't go to have a shower, I can't do my cooking, because I have to constantly be aware of their actions and what they're doing. It's also learning a whole new way of communicating. You can't be challenging, you can't be irritable, because they don't genuinely understand what's happening. They can be really rude, they can be quite nasty, they can be undermining of your efforts, they can be resistive to all the care you're giving them, and all of that has a huge physical impact on a carer. Also, their sleep goes. They have very disturbed nights, which means you're not sleeping. So you're getting, every time they turn and move in bed or you hear a door going, you're jumping up thinking, have they gone out? Are they okay? Have they fallen? So on a one-to-one, the carers have an incredibly difficult job, physically and emotionally. Socially, for carers, they then become withdrawn because you can't go out with them. You can't go out with your partner or, whoever. You can't leave them and go out. People coming over, you don't know how the person's going to behave. You don't know how they're going to react. So that becomes an issue. And I think there's a huge sense of embarrassment as well, which shouldn't be, but there is a sense of embarrassment and a stigma that goes with any mental health issue. So carers have a very difficult time on all fronts. And I think caring for the carer means trying to get as much of a network of support around them as possible. So, if you have family members, start introducing family members, sitting with the person for a few hours a day or an hour even, just to give you some respite. But keeping in mind that as the dementia progresses, they will want that one person there all the time. They get very restless when they can't see them. You can't take them out to respite to say, right, you go to your daughter's house for a little while. They don't like new environments. It's confusing. The carer feels very boxed in, very tied up. And I think that's why having support groups, having day centers where both can go. So there's someone to look after your loved one while you just have a chat with someone or have a coffee or, whatever. That's crucially important. I think it's a movement that started now where churches have it. They have a coffee morning where it's an enclosed space, it's a safe space, even if they get up and wander around, it's okay. You have that support, whether it be spiritual or, just the camaraderie of other people who have similar problems. So these are ways that we can care for the carers. Respite is hugely important. Giving medication to manage the behaviors is very important. Having that break and that time away so that you come back refreshed, because as the carer gets more and more tired and more worn out, the responses and the reactions can be quite impulsive and hostile. And that can be very, very, dangerous in a way. because then you have two people who are arguing and one person doesn't know where it's coming from. So there's a lot that needs to be done for carers. I don't know that we have the infrastructure in India as yet, but it's something that is developing. So yeah, the carers do have a rough time.
Thank you. I just want to add things that I've picked up along the way from different situations, both negative as well as positive. I think the immediate circle needs to know what this is all about. Because if it's not, they see it as a stigma, they hide this person away because they're afraid and embarrassed what will happen. Some of them don't get into it. So if they get into an aggressive mood or say something, you hit back at them hard, pull instances of the past to, you're not dealing with a person who's in full sense of their faculties. And sometimes family members can say harsh things. Oh, you do remember what you did this, you said this over there, and only with us you behave, with others you seem to be all okay. And this kind of language is not helpful. So this is part of the negative thing that and the stigma that we attach to it. Sometimes, unfortunately, there's a religious element. You have done something in the past, now this is visiting. And what a terrible, terrible thing to say. I'm putting it out there because this is things that I've heard. Some of it loosely use the word, not in the religious sense, but in my karma, you've done something, now it's visiting you back. None of that. Please let us not go down that road. So I think we need to be aware of the negative dimensions, which instead of making it easier for this person, we just get into a confrontational, provoking more agitation. And I think this is something of the negative thing that we must be conscious about. We read, inform ourselves, and hopefully this conversation will throw a little more windows to look at in terms of that negative dimension that really adds to the burden of the person who's going through that.
But Father Juvie, I think it's easier said than done, because when you're in that environment all the time, now most dementias will end up with what we call aphasia, where the person knows what they want to say, but they can't get the words out. They can't articulate the words. So you're sitting there double guessing. Do you want water? Do you want to go to the toilet? What do you want? And you initiate something and they really lose it with you because that's not what they want. But how do you know? Because they can't articulate it. It's in their head in a confused way, but they can't say it. So that's where, learning the patient becomes so important. Right, she's getting really restless, she's getting irritable, maybe she's hungry, maybe she needs to go to the toilet. So, with the aphasia, that adds a whole different dimension to it. If they can articulate what they want, it's that much easier. But what happens is if you do the wrong thing, then if you bring them a cup of coffee and they didn't want it, they could throw it at you. Because you're not giving them what they want, but they don't realize that the words they're saying or the sounds they're making, you don't get. It isn't really saying anything.
Yes.
So it is really difficult. It is difficult.
It gives a whole new meaning to what we sometimes loosely refer to as the second childhood.
Yes.
Because again, babies cry, we don't know why, we're trying to, and then after a while when you know your baby, you know how to respond to that person. And I think it gives a whole new understanding and a better meaning to what we refer to as the second childhood. I'm going to take this was what I said as the negative part. The positive is, how do we, trigger happy memories in our conversation? Especially those going back to the earlier times. I've known places where the caregiver has put a whole collage of photographs of the family members or those who have the images that they scroll. So this person might be thinking and just staring into space, but they're looking at all these familiar faces of the family, the children, the grandchildren, the spouse, whoever. And I think these are all positive ways. I've seen this from pastoral practice that enhance, as you said, the earlier memories. We are affirming that in a sea of turbulence, you at least have this small little oasis of calm, because these are happy and gentle memories.
And music is very important,
Yes, that's
as well. Their favorite music, if it's playing in the background, seems to calm things down quite dramatically.
I remember my dear dad, in his fading years, because he was confined to the home, my sister would play the rosary so he could just join along with him when she was not able to pray, or my brother. On the other hand, she would play church music that was so familiar, and he would just be conducting as though it was there. You know, the simple things that just brought so much of meaning into his life, or the novena that was just played out. He would just listen. So these are different ways where we use different resources to bring them into that certain center of peace in the midst of all the storm that they are going through, and which we can't fully fathom.
Sure.
Angeliqueka, what are the connotations, the legal connotations of making a will? And also, when is it too late when it comes in terms of incapacity? And another question is, when that will is written, what are the risks of it being challenged later?
Doctor, my question is for you. We have a lot of, I have a lot of friends who have children abroad. So how would they know when their parents need to be institutionalized? That is, and another thing, even sometimes I have seen my son-in-law struggle with his dad. He passed away at 92, got dementia. He was this wonderful, on the who's who of India list. And he was not only CEO of a major shipping company, but he also was an author. He has written 5-6 books. So it was terrible for him So would he have been better in an institution?
How do we handle this whole problem of dementia in a family? Sometimes we feel a certain amount of guilt. Have we done the right thing? Have we done enough? Whether this disease will progress, or have we done less for them? So because of us, it's progressing. Something like, can you give a heads up on that?
Dr. Angeliqueka, sometimes we have patients who come and share their experiences, and when we finally investigate or when we check up, we find that it maybe never happened, or maybe it's totally different from what they have told us. And so it becomes really difficult, because they may be crying, they may be and we really feel really helpless when we listen to them. And so how do we how do we respond to such people?
This brings us to the end of the first part of this episode on our discussion of mental health in aging. We will continue this discussion on our next episode of Aging Gracefully, a talk show for Evergreens. Please subscribe to our YouTube channel and like and share this video with your friends and family. We also welcome your comments in the comment box below. Until then, it's goodbye from all of us at Aging Gracefully, a talk show for Evergreens.